terms of doing some really nice research in neurofibromatosis, and she's actually establishing a clinic in that here at Mount Sinai. So this is, a really nice endeavor on her part, and it builds off some research that she did as a resident with an R25 here at Mount Sinai, where she really looked at some of the Nf1 gene functions in neurofibromatosis. So Rebecca completed her Sloan Kettering Neuro-Oncology Fellowship, and we were lucky enough to bring her back here. And it's been, I guess, about a year. So Rebecca, really looking forward to your talk, and we're happy you're part of our team.
Thanks so much for the introduction, Costas. Let me just pull my PowerPoint over and see if I can share my screen. Is my screen visible?
Yes.
Yes.
Yep.
Looks okay. Okay. So my background is in basic laboratory research. However, when I transitioned to Mount Sinai, I came here because of the possibility of opening up a clinical center for neurofibromatosis, which I'm going to talk about a little bit at the end of the talk. This talk is going to focus on a clinical update of neurofibromatosis type 1, type 2, and Schwannomatosis. And so I'm not going to talk about my basic research, but of course, if there are questions, I'm happy to address those as they come up. Oh, and I have no financial disclosures. So there are 3 types of neurofibromatosis, and this diagnosis is really allied by a shared proclivity for the formation of peripheral nerve tumors. However, the neurofibromatosis type 1 is very different from the joint association of neurofibromatosis type 2 and Schwannomatosis, and I'll be talking about that a little bit later. As far as prevalence goes, Nf1 occurs in approximately 1 in 2,500 individuals. I think it's probably underreported because many patients are asymptomatic or have few symptoms and do not follow with a specialist for this condition. So it is the most common tumor predisposition syndrome. There are approximately 3,400 individuals in New York City alone who have this diagnosis. If you talk to
Rebecca,
the patients...
Sorry to interrupt. Can you put it on presentation mode? I think you have it. We're seeing kind of...
I see.
It'll enlarge your presentation for us.
I see. Let me see what I can do.
Sorry to interrupt.
No.
If you can't, just keep going.
I think what it did is I have 2 monitors and it decided to put up the wrong monitor. Okay, just give me a second. I'm going to fiddle with it. How's that?
Much better. Thank you.
Wonderful. Thanks for bringing that up, Costas. So if you talk to patients who have neurofibromatosis type 1, their major concerns are that the cutaneous manifestations of this disease are highly disfiguring, and that also that there is a high risk of malignancy in these patients. On the other hand, neurofibromatosis type 2 and Schwannomatosis are characterized by the growth of peripheral nerve sheath tumors of a Schwannomatous pathology. Nf2 occurs in approximately 1 in 40,000 individuals, in Schwannomatosis 1 in 75,000. So it's far less common. And the stigmata of Nf2 include progressive hearing loss to the point of deafness, as well as the recurrent growth of multiple meningiomas. Schwannomatosis is by far more rare, and really the primary complaint of patients is that of unremitting pain. So a little bit about the history of Nf1. It has a long history in documented literature. However, the oldest documented case that is definitively a case of Nf1 was defined in the 1400s, and the patient was described as having a condition called monstrorum. In 1781, the pathologist Odier described a patient with multiple cutaneous neurofibromas that he named Wortman. And in 1830, Schwann published a study describing a preponderance of nerve sheath cells within the tumors that were at that time called neuromas. in 1847, Virchow described a family that was plagued by these neuromas. And in 1882 is when von Recklinghausen, who named the condition, recognized neurofibromatosis type 1 as a nosological entity. And the disease was for many years described as von Recklinghausen disease. It still is if you Google it today. And he described multiple neurofibromas that were postulated to arise from major nerves. And then he distinguished these from what were called false neuromas arising in the skin from nerve sheaths and nerve plexi. We now know that these false neuromas are true cutaneous neurofibromas and cafe au lait macules. I wanted to point out, just because of the falsehood that's out there in history and common knowledge, that Joseph Merrick in 1862 to 1890, who was described as the Elephant Man, did not actually have Nf1. He had a related rhasopathy syndrome known as Proteus syndrome. It wasn't until 1990 that several labs sequenced the Nf1 gene, and this was mapped to chromosome 17q11.2. And in 2012, the first clinical trial of targeted therapy against plexiform neurofibromas was conducted with some success. So the Children's Tumor Foundation is the #1 organization that promotes research and education for the neurofibromatoses. And I wanted to mention that the diagnostic parameters for Nf1 were updated as of this year. And for Nf2 and Schwannomatosis, they're likely to be updated within the next year as well. So the diagnosis previously was purely clinical, and it involved the presence of at least 2 of the following clinical signs. A distinctive osseous lesion. So Nf1 haploinsufficiency in osteocytes is related to osseous lesions that can cause very severe scoliosis, as well as thinning of the long bones, namely the tibia, as well as the radius, that can cause pseudoarthroses and sphenoid wing dysplasia. Patients can also have an optic pathway glioma. This was updated this year. Previously, it was called an optic nerve glioma. However, these tumors can arise anywhere along the optic pathway between the globe and the primary visual cortex. The patient may have 2 or more benign hamartomas of the iris known as Lish nodules. And what was added this year was choroidal abnormalities. And then Crow's sign, which is freckling present in the axilla and the groin. Cafe au lait macules are these benign melanocytic macules of the skin. In order to count as a criterion for Nf1, they must be of a certain size in prepubertal children versus adults, and that's listed here. And then, of course, 2 or more of any neurofibroma tumors, including cutaneous neurofibromas or plexiform neurofibromas. So added this year as well was a pathogenic variant of the Nf1 gene. This has been late in being added to the diagnostic criterion, and I'm going to talk a little bit about the molecular genetics of the Nf1 gene. However, it is now considered one of the criterion. It is not alone sufficient to diagnose Nf1. The patient must still have some of the stigmata of Nf1. And then also this year, instead of the terminology having a first-degree relative with Nf1, it's now been limited to a parent with Nf1. So Nf1 can be defined in multiple ways. One of the ways that it can be defined is molecularly, and I bring this up because I'm going to talk a little bit about some of the clinical trials that have been conducted in plexiform neurofibroma and the targeted therapies that have been used. But Nf1 is a rhasopathy, meaning that the function of the Nf1 protein, neurofibromin, is to inhibit RAS signaling. And downstream of RAS signaling is PI3 kinase, AKT, and mTOR along one pathway, or RAF, MEK, and ERK along the second pathway. And MEK is really one of the targets that has been most successful for treating plexiform neurofibromas. So neurofibrin is also known as a GAP protein. This is a GTPase activating protein. And this class of proteins is effective at reducing GTP to GDP, which inactivates second messenger pathways. And that's what Nf1 does in order to inactivate RAS. So also, I'll just mention here that Nf1 fits into Knudsen's 2-hit hypothesis for carcinomagenesis and tumorigenesis, meaning that haploinsufficiency of the NF1 gene is not sufficient for tumor growth. There must be an event that enacts loss of the second functional protein in order for tumors to grow. So in addition to describing NF1 as a restopathy, it can also be described as a neurocrystopathy. So this refers to the fact that although neurofibromin is expressed in every cell in the body, it's really thought to be crucial in the Schwann cell precursor cells. So these cells originate from the neural crest, which develops dorsal to the nodal cord, and the dorsal aspect of the neural crest migrates out of the neural crest through the burgeoning boundary cap cells and the nascent dorsal root ganglia. And from there, they migrate down along extending peripheral nerves, and these cells are able to develop ontologically into neurons, Schwann cells, and melanocytes, amongst other cells. And when the second hit occurs, determines the tumor manifestations of the disease. So if the second allele is lost in a dividing cell early on in the dorsal root ganglion or in the boundary cap cells, this can lead to development later on of a plexiform neurofibroma. So plexiform neurofibromas are felt to be present in a seed form at the time of birth. And the reason is that the second hit has occurred very early in embryonic development. So because of the preserved multipotency of these cells, they're able to develop into any of the cells that can derive from neural crest cells. And they do, and these tumors are highly infiltrative. They are comprised of many different cell types derived from Schwann cell progenitors, as well as the incorporation of a large percentage of tumor parenchymal cells. So they are incredibly infiltrative into the skin, bone, and muscle. They are impossible to completely resect without amputation, and they retain an unlimited growth potential throughout life. So if the second hit, however, occurs late in neural crest Schwann cell migration, they've already migrated far from the developing spinal cord. At this point, their ontologic fate has been mapped, and these cells can develop only into melanocytes, and that's why you see cafe au lait macules, and as well as freckling. So, however, cutaneous neurofibromas really develop late in childhood into early adolescence and through adulthood. And it's thought that in these cells, it's actually a latent, sort of a sleeping population of multipotent Schwann cell precursors that is activated either through the injury and repair mechanism or for other reasons that we don't clearly understand. When the second hit occurs in these cells, it leads to development of cutaneous neurofibromas. And one thing to note is that plexiform neurofibromas often contain both cafe au lait macules and cutaneous neurofibromas over their surface. And that, again, is due to the multipotency of that cell population. So I did mention that I was going to discuss the clinical genetics of NF1. It's a really fascinating gene, and it's a very fascinating condition. So the gene itself is the second largest in the human genome. It contains over 350 kilobases, as well as over 60 exons. It also contains 2 genes that are expressed in the opposite direction, so not the 5' to 3' direction, but 3' to 5'. It contains, because of duplication events throughout evolutionary history, there are multiple pseudogenes on different chromosomes. And then the gap-related domain, which is the domain that's actually responsible for inhibiting RAS signaling, is highly conserved, not only in NF1, but also in other gap genes. And it has a very low GC content. The reason that I mention these particular factors is that many people have questions about genomic editing techniques, such as using CRISPR in human patients. While this has been helpful in other conditions such as cystic fibrosis, these particular qualities of the NF1 gene make it very difficult to target because there would be predicted many different off-target effects as well as a particular GC content is required in order to enact genomic editing. So Nf1 is not a very good candidate. It is found that the gene has approximately 10 times higher mutation rate than other genetic conditions, even given the complexity and the length of the gene. This cannot be explained, and we're not clear on why this occurs. There are no mutation hotspots, again, making genomic editing highly unlikely because each individual patient would have to have a different targeted mutation repaired. And 80% of the mutations that occur in this gene either directly or indirectly induce a premature stop codon, so the pathology is thought to be related to a truncating mutation. There are, in addition to mutations that can be detected in the exons or at splice sites, there are also silent mutations that are not detected by classical genomic sequencing techniques. And these can include multi-exon deletions, inversions, or whole gene loss. And this is why the diagnosis of Nf1 for many, many years did not require, and in fact, did not support the use of genomic sequencing techniques and genetic analysis as one of the diagnostic criteria. So also Nf1 is fully penetrant, so mutation anywhere along the gene is likely to cause the condition. However, there's extreme phenotypic divergence that can occur between and within families, even when the same mutation is present. And here, the image that I show you is just a histogram of mutation location along the gene. And you see that there are, and this was a case series of approximately 300 patients. And you could see that mutations can indeed occur in any of the exons along the Nf1 gene and cause loss of function of that gene and the disease scenario. So a little bit more about the mutational spectrum of Nf1 and associated tumors. So malignancy in neurofibromatosis derives almost 100% from precursor tumors, which are benign. So cutaneous and plexiform neurofibromas are posse-mutational. They are only characterized by biallelic loss of Nf1. After the development of a second mutation, which would be actually a deletion of CDKN2A and 2B, these tumors develop a more malignant appearing growth rate, and this qualifies the tumors as an atypical neurofibromatous, neurofibrinous neoplasm of uncertain biologic potential, or an ANUP, which may be one of the worst acronyms in medical history. And finally, the addition of further mutations leads to the development of a malignant peripheral nerve sheath tumor. And I just want to highlight here the genetic diversity of Mpnsts. These are rare tumors, but in addition to that, again, there are no real hotspot genes that are mutated across the spectrum of patients with Mpnst. Each individual tumor, even if a patient has multiple Mpnsts, each individual tumor is extremely genetically diverse, and this really does complicate treatment of this disease. There has really been a failure to identify effective treatments. And all that we do know is that when Mpnsts do develop, those tumors are no longer reliant upon Nf1 loss. They're no longer reliant upon the RAS pathway or the PI3 kinase pathway. They have developed further mutations that free them from targeted treatment against those pathways. And the way that that occurs is through loss of cell cycle regulation, epigenetic dysregulation, as well as increased tyrosine kinase signaling, thought to be less important for these tumors, and hypermutation, including chromothripsis, which is defined as widespread genomic alterations, multisomies, as well as breakages occurring in multiple chromosomes. So to start with the clinical features of neurofibromatosis type 1, the first and most obvious visibly would be cutaneous neurofibromas. These tumors have zero malignant potential. They will never develop into a cancer. However, they are highly disfiguring, and they can be symptomatic, causing pain or pruritus. Previously, these were requirements from insurance companies in order to bill for resection, but now through the work of the Children's Tumor Foundations, it's recognized that psychological distress caused by physical disfigurement can also count as a reason to remove these tumors. So in addition to contributing primarily to anxiety and depression in these patients and psychosocial distress, it also confers an economic disadvantage because patients are unable to be offered the same jobs and the same visibility as people who don't have this condition. And the only treatment for cutaneous neurofibromas is physical removal. This can happen through surgical resection, although I do have to say that tumor regrowth is highly associated with surgical resection, particularly at suture sites. And it's thought that the suture provides irritation that enacts that trauma and injury pathway in Schwann cell precursors and leads to regrowth of cutaneous neurofibromas at suture sites. Also, there's a high incidence of scarring at the site of the resection. Other alternatives include electrodesiccation and carbon dioxide laser ablation. Plexiform neurofibromas are those more multipotent tumors that I described that are present embryonically and at birth. They have unlimited growth potential throughout the lifetime and also unpredictable spurts and lags in their growth. So the radiograph that I show you here is that of a 3-year-old child who had a head and neck plexiform neurofibroma. This was back in 2010, that was compressing and diverting her airway and was really growing to a point where it was no longer compatible with life. And she was the subject number 1 for the first targeted therapy tested against neurofibromas, which was a c-KIT inhibitor known as imatinib. And you could see in panel 2 that the tumor did shrink quite a bit on this therapy. So here's another example of the phenotypic divergence between 2 individuals who shared the same familial mutation. The individual on the right is an actor. His name is Adam Parson, and he was in a film entitled My Amazing Twin. His brother Neil on the left shares the exact same germline Nf1 mutation. However, Adam unfortunately suffers from a plexiform neurofibroma of the head and neck, whereas Neil doesn't. So approximately 30% of Nf1 patients do have a plexiform neurofibroma. They may be unaware that they have it because it may be located in the deep tissues of the paraspinal region. And again, these tumors have unlimited growth potential and are highly infiltrative and have malignant potential as well. So the treatment for plexiform neurofibromas historically has just been repeated debulking. However, now with the development of MEK inhibitors and other targeted therapies, it is possible to utilize a pharmacotherapy against these tumors. They can grow anywhere in the body, typically along large nerves and nerve plexi, and approximately 50% of them are located in the limbs, 30% in the chest, abdomen, and pelvis, and the remaining 20% in the head and neck. So it is difficult, if not impossible, to achieve gross total resection due to the infiltrative nature of these tumors. And the pharmacotherapy that has previously and is currently being tested includes mostly tyrosine kinase inhibitors. However, because these tumors have lifelong growth potential, the tyrosine kinase inhibitors must be also administered throughout the lifetime, either recurrently or chronically. And there has been an issue that during exposure to these medications, the receptors on the cell surface are internalized and feedback inhibition is downregulated. And then when the drug is stopped, there is a rebound explosive growth effect of these treatments. And so really the research into the utility of the timing and the exact recommended therapy for these tumors is still very important and very much underway. One other thing I should mention, these are some of the drugs that have been tested. The one that has been approved in 2019 is selumetinib, FDA approved for pediatric plexiform neurofibroma. There's no FDA approved drug yet for adult plexiform neurofibroma. However, part of the limitations of these trials, before I go through them, is that you have to choose a target lesion. And a lot of times these drugs will enact shrinkage of a lesion that is not the target lesion, which can interfere with the described overall response rate as well as the percent change in the tumor size. And this can really create some noise in these trials that makes it very difficult to interpret the difference between different drugs. In fact, the trials that did not require the target lesion to be a symptomatic lesion were much more likely to fail at meeting the statistical endpoints, because some of the plexiform neurofibromas may shrink and others may grow within a particular individual. So one thing to note is imatinib here was the first clinical trial drug. It's actually a c-KIT and PDGFR inhibitor, and it was tested in both pediatric and adult patients with a moderate response rate. Really, the drug that has been the most effective was the FDA-approved selumetinib. If you look at how it has 70% overall response rate to target lesions, there have been 4 clinical trials that have been published with variable results. If you notice the one trial, the third one down in the bullet points, that looked at asymptomatic, so it did not require symptomatic target lesions, showed a gross 29% median increase in the size of the tumors, and that's what I was referring to earlier. There are other MEK inhibitors that are actively being trialed with variable overall response rates. So the real risk of malignancy in NF1 patients, I mean, they're at risk of breast cancer, gastrointestinal stromal tumors, neuroendocrine tumors, but really the life-limiting diagnosis is malignant peripheral nerve sheath tumors. These tumors have a really terrible overall prognosis with a median overall survival after diagnosis anywhere between 18 months and 5 years. If gross total resection is possible, patients can be cured. However, that tends not to be very common with NF1 patients. So there's really this brilliant paper that was published in 1930 by Kiyoshi Hosoi over at Albany. He was a pathologist. And one thing that he noted in his patient was that when the malignant peripheral nerve sheath tumor is resected, it initially is encased in a fibrous capsule, but quickly after that time it recurs. And his hypothesis was that there was something about the physical damage to the tumor that led to recurrence. And this patient of his, shown on the left panel, had a malignant peripheral nerve sheath tumor that had converted from a plexiform neurofibroma of the neck, and underwent multiple resections and ended up ultimately dying from his tumor. But I thought that it was very, very forward thinking of this researcher, this pathologist, to note that what we know now, which is that these tumors really need to be resected en bloc. When they are not, there's seeding of the local anatomy and very much higher risk of hematologic dissemination and metastases of these tumors. So some statistics for malignant peripheral nerve sheath tumors. Each NF1 patient has approximately a 10% lifetime risk of MPNST. A heavier burden of plexiform neurofibromas increases this risk. The peak age at diagnosis is young adults. Really, it's between 20 and 40 years old. However, they can occur at any age. A prior history of malignancy predicts recurrent malignancy, and any family members who had a malignant tumor, first-degree relatives especially, will increase risk of the proband patient and require more frequent surveillance imaging. So about 5 to 10% of NF patients who have a diagnosis of MPNST subsequently develop a secondary MPNST. And median overall survival really depends on several factors: the size of the tumor at diagnosis, whether the resection was complete or not, the grade of the malignancy, and whether or not there are metastases at diagnosis. And then there's also a difference between sporadic MPNST and NF1-associated MPNST. This tumor is 1,400 times more common in NF1 patients. Probably the tumors are biologically equivalent, but outcomes are far worse in NF1-associated MPNST. The 5-year overall survival is much lower in NF1 patients than it is in sporadic cases. And I'm showing you a waterfall plot on the lower right there, with the red line indicating the survival percentage of NF1 MPNSTs versus the blue line showing sporadic. So why is this? One of the reasons is that Nf1 patients have a very high tumor burden of plexiform and deep tissue paraspinal neurofibromas, which makes it difficult to localize symptoms when they arise. Current guidelines are that when a patient develops symptoms from one of these plexiform tumors, that's the time at which to increase frequency of surveillance to look for tumor growth, as well as to conduct PET-CT scan if possible to detect high SUV that might be associated with malignant conversion. But determining exactly which tumor is the culprit can be very difficult. Also, imaging is not diagnostic of malignant conversion. This PET-CT scan that I'm showing is a patient of mine who I'm currently treating for a malignant peripheral nerve sheath tumor. This is a post-resection scan. So initially, the malignant tumor that's indicated in the pelvis was 11 centimeters by 8 centimeters in size. It's now post-resection, but what I wanted to show you is that the SUV of the malignant tumor is the same as the SUV of the posterior thigh tumor in his left thigh. However, the posterior thigh tumor was biopsied multiple times and found to be benign. And so the imaging did not absolutely diagnose that as a malignant tumor. So also, there are unique sequelae of treatment, including resection in Nf1 patients. The paraspinal plexiform neurofibromas, they tend to be very fibrous and collagenous. So they actually provide structural support during childhood, birth and development, and strengthening of the paraspinal muscles and growth of the spine itself. And resection of these tumors can actually destabilize this acute scoliosis that we see in our Nf1 patients and worsen their symptomatology and their functional performance. So there's also can be loss of major nerves and loss of function with gross total resection. So the patient who I show you in the center panel there has opted to not have a gross total resection of his malignancy despite the life-limiting prognosis, because it would require sacrifice of his femoral nerve. And then in addition to that, 3 to 5% of patients receiving radiation therapy suffer from radiation fibrosis or necrosis, including radiation plexopathy. And so the role of radiation in treating these tumors is poorly supported, and there's a lot of controversy. And of course, patients can develop a secondary malignancy after receiving radiation. So treating a malignant peripheral nerve sheath tumor is not a direct, there are not direct guidelines for this. So I'll tell you my clinical practice, which is that every time I see a new Nf1 patient in clinic, I perform a whole body MRI. After that, I perform intermittent close monitoring of their symptoms, as well as an MRI with DWI. So you don't want to expose these patients to too much radiation from recurrent CT scans. So really you want to reserve a PET-CT for when they develop new and concerning symptoms, or if it appears that the tumors are growing on MRI. And contrast enhancement is not absolutely necessary even for these patients. The tumors really light up on DWI. So I mentioned that we do PET scans if there's concern for tumor growth, especially above 5 centimeters. And my recommendations is if the SUV on the PET scan is greater than 3 and the patient is symptomatic, to go ahead and resect the tumor, even if a biopsy shows a benign tumor. And this is because there are subregions of these very large tumors that can undergo malignant conversion, whereas other regions can remain benign in pathology. And so it can be very difficult to detect. There are a lot of false negatives from biopsy. However, if the SUV is less than 3 and the patient is symptomatic, then I monitor. I always aim for gross total resection. And if there is tumor remaining, I would consider radiation. Of course, the age of the patient and the risk of fibrosis and necrosis is always a consideration. Clinical trials are amazing, but this is a rare disease and they are few and far between. And if necessary, I will offer chemotherapy. The regimens that are typically used are doxorubicin ifosfamide or cisplatin etoposide. However, the overall response rate is actually very low to achieve just mere stable disease. So no growth of the residual tumor. That only occurs in 18%. And these chemo regimens are very toxic to the patients with very poorly tolerated side effects. What other providers do is about 42% of patients in the literature undergo resection alone, approximately 25% resection, chemo, and RT, 20% resection with RT, and 14% resection with chemo. So moving on to Nf2 and Schwannomatosis. So one thing to note here is that Nf1 is on chromosome 17. Nf2 and Schwannomatosis is both of these conditions are caused by mutations or deletions on chromosome 22. So this shows you that the associated genes with schwannomatosis, LZTR1 and SMARCB1, are located just upstream of the Nf2 gene. And that actually comes into play into the clinical similarities of these two conditions. So the etiology of Nf2 is that there is a deletion or mutation on chromosome 22q. The protein that's expressed from this gene is Merlin, which inhibits the Hippo and YAP-TAZ and PI3K and mTOR pathways. So slightly different pathways than in Nf1. This gene is also felt to be most important in Schwann cell progenitors, but localized to different anatomical regions than in Nf1. And the prevalence is far rarer. Up to 35% of cases are actually chimeric. And so a germline mutational analysis has a high risk of failing to diagnose a germline condition. This is why ideally you would have two independent tumors that you can send for pathology. And if both of those tumors contain the exact same Nf2 mutation, then that is much more likely to provide a diagnosis in the case that the patient does not meet clinical criteria. So the signs of this condition are bilateral vestibular schwannomas, which are present by 50 years of age. Although not every patient has imaging by 50 years of age, they may have a history of hearing loss in the absence of imaging. Also peripheral nerve sheath schwannomas and the growth of multiple meningiomas, ependymomas, and the occurrence of juvenile cataracts. So the symptoms of vestibular schwannomas is a sensorineural progressive hearing loss. That's the presenting symptom in 90% of patients. And the onset is typically late adolescence and early adulthood, but we also pay attention to patients who complain of this later in life because there is variability. Tinnitus occurs in over 60% of patients, and facial paresthesias and facial nerve palsies are typically a late presentation of disease associated with a much larger tumor bulk. So the risk of Mpnst from vestibular schwannomas associated with Nf2 is close to zero. I never say it's absolutely zero. However, after radiation exposure, there is a less than 1% risk, but a present risk of a conversion to a malignancy. And this typically occurs at approximately 3 years after stereotactic radiosurgery. The size classification for both Nf2 and sporadic vestibular schwannomas is small, medium, or large, based on the diameter as given in the table below. So again, it's similar to sporadic versus syndromic Mpnst. There are differences between sporadic and syndromic vestibular schwannomas in Nf2. Some special considerations for vestibular schwannomas in Nf2 is that the geometry of the tumor is multilobulated. And the reason for this is, and the reason that these patients acquire bilateral vestibular schwannomas at such an early age is because it's not a singular tumor. What we're actually seeing is repeat de novo mutation in multiple of these Schwann cell precursors that leads to a multitudinous tumor that's formed of multiple different second hit mutations. And the figure on the right demonstrates this. It shows the germline mutation on the chromosome on the lower left and the somatic mutation on the lower right. And you see that at different parts of this vestibular schwannoma, if you sample and perform genetic analysis, you see that there are different second hit mutations. In addition to that, Nf2 vestibular schwannomas are much more adherent to the facial nerve and local anatomy. They may be less sensitive to radiation. This is up for debate. And there is this risk of malignancy that's small but present after radiation for Nf2 related vestibular schwannomas. The risk of malignancy in sporadic vestibular schwannomas is actually a bit higher. So small or medium tumors, the recommendation is to conduct surveillance imaging and recurrent audiometry and to watch. And the reason is that, again, these tumors have lifelong growth predictions. And so once you surgerize the patient, there are only a certain number of additional times that the patient can undergo tumor debulking or resection. And so we don't do it until it's absolutely necessary. And then also the goal for these patients really is preservation of hearing, since the risk of malignancy is so low. So there have been a couple of studies that have compared radiation versus surgery for Nf2-associated vestibular schwannomas. I will tell you that in the neurofibromatosis realm, surgery is, as a rule, preferred. And one of the reasons for this is hearing preservation at 1, 3, and 5 years is much better at surgery. And I did mention earlier that preservation of hearing was the primary goal of treating these tumors for these patients. So with SRS, the mean 5-year local control is a little bit less than for surgery, 75 versus 92%. Hearing preservation is also a bit less, about 40% versus 52%. And however, facial nerve preservation is a bit greater. And this has to do, again, with the fact that the Nf2 associated vestibular schwannomas are so closely adherent to the facial nerve. So Avastin or bevacizumab is a VEGF monoclonal antibody that has been successful in treating vestibular schwannomas, both sporadic and Nf2 associated. So if you look across I've sort of summarized the bulk of studies that has been published. Approximately 40% of tumors respond, including there's the response criteria across the board for neurofibromatosis is 20% decreased tumor volume. 70% of patients experienced stabilization of their hearing, which was previously declining, and 20% of patients experienced improved audiometry. 17% of patients, however, which is not insignificant, suffered from grade 3 adverse events, most commonly hypertension. But in one of the clinical trials, there was a case of mortality from spontaneous intracranial hemorrhage in a 23-year-old woman with no known risk factors. So bleeding, clotting, hypertension, proteinuria are common with bevacizumab. What we do know with our Nf2 patients is that the dose that we can use is much lower than the dose that we employ for other types of tumors. And so the minimum dose requirement is being explored currently in clinical trial. There's approximately an 11% treatment failure. These patients may require subsequent tumor resection. And the largest prospective trial, including 61 patients, was published in 2016, and it showed an 82% overall response in hearing preservation in 95% patients, which is pretty positive. So just a couple slides on schwannomatosis, and then I'll be happy to take questions. So schwannomatosis is not a genetic diagnosis. The genetic diagnosis, when possible, is wonderful, but approximately 50% of patients, there is no identifiable gene mutation that's detected. And 9% of patients with clinical schwannomatosis are actually subsequently diagnosed with Nf2, and this has to do with the chimeric nature of Nf2 in 30% of cases. They may have peripheral schwannomas and no bilateral vestibular schwannomas, and that may just be due to where the gene mutation is located in a chimeric fashion. 12% of patients with clinical Nf2 are actually subsequently diagnosed instead with schwannomatosis. And again, this has to do with the overlap between these two conditions. 75% of patients have no family history, and the prevalence is pretty rare, we think, although again, I think that this is highly underreported. So SMARCB1 and LZTR1 are those two genes I mentioned that are upstream of Nf2, and those are the two genes that are known to be associated with schwannomatosis. SMARCB1 is important to distinguish because it comes with an associated risk of meningioma, whereas LZTR1 does not. So the craniospinal imaging requirements of a SMARCB1 mutated schwannomatosis patient are different than those of an LZTR1 patient. Also, the mechanism by which tumorigenesis occurs in schwannomatosis is not a Knudsen's 2-hit mechanism, but rather a 4-hit mechanism. So what must occur is that the SMARCB1 or LZTR1 are mutated in one gene. The cell then subsequently undergoes loss of the contralateral allele for that same gene as well as Nf2. and then loses Nf2 in the initial allele. So it's very complicated four-hit mechanism. But the main point I want to make here is that it's not actually loss of SMARCB1 or LZTR1 that causes tumorigenesis. It's actually loss of Nf2. And that's why there's so much overlap between these two conditions. So the diagnosis of schwannomatosis is kind of complicated. Basically, you have to have more than one non-intradermal schwannoma, one that has a pathologic conformation and no bilateral vestibular schwannomas, or you can have one pathologically confirmed schwannoma or intracranial meningioma and a first-degree relative. And then there's these possible diagnostic criteria. Chronic pain increases the probability that the patient actually has schwannomatosis, because I mentioned that chronic unremitting pain along the lines of a fibromyalgia is highly associated with this disease. And here is my individual schwannomatosis diagnosis and treatment approach. What I like to do is submit 2 individual tumors for next generation sequencing. If the tumors share an identical Nf2 mutation, then it's most likely they have a chimeric Nf2, assuming that their germline mutation analysis was negative. If they have an identical LZTR1 or SMARCB1 mutation, but different Nf2 mutations, then they have a diagnosis of schwannomatosis. And then also, if they have unique Nf2 mutations and no LZTR1 or SMARCB1 mutations, then they meet a clinical criteria for schwannomatosis, and we've ruled out chimeric Nf2. So the treatment for these tumors is symptomatic. You can ablate the tumors if the nerve is able to be sacrificed. The tumors can be debulked if the nerve cannot be sacrificed and the tumor is accessible, or else pain management. And really, none of the clinical trials of pain medications, anti-epileptic medications, SSRIs, nothing has really worked for these patients. It's really unremitting pain, and it can be really debilitating. You know, I've had patients who are in their early 20s who are unable to work and are bedbound and at home because the pain is so severe. So that concludes my description and update of the neurofibromatosis. I just wanted to put in a couple of slides about the NF clinic here at Mount Sinai. So the vision for this NF clinic is to really incorporate multidisciplinary collaboration from all of the specialties that might be seeing these NF patients. Every single patient, the goal eventually will be to consent every single patient to research at their first appointment. And this would be for donation of tissues, as well as any other research studies that might be ongoing. And then every physician who's formally associated with the clinic should commit to research using this information. Really, the bottom line is patient-directed care. And what this means is that I'd like to address the concerns that are most bothersome to the patient. And these are not necessarily the concerns that are most bothersome to the clinician. So if you talk to NF1 patients, they're actually more concerned about the physical stigmata of their cutaneous neurofibromas than they are about the risk of malignancy. Although the malignancy does concern them, the cutaneous neurofibromas bother them the most. And so they're really looking to partner with a physician who's going to address those concerns. Also, communication is extremely important. The NF clinic and my role in it is somewhat of a secondary primary care physician in order to coordinate amongst all of their different physicians and their different conditions to make sure that they're receiving all the surveillance they need. For example, breast cancer surveillance in NF1 patients and mammograms. Also, we're providing family-based care. So NF1, Nf2, and schwannomatosis are genetic conditions. That means when a proband is identified, that the rest of the family can also be looped into the clinic. And I'm working very closely with pediatric neuro-oncologist Praveen Raju, who sees children and I see adults on the same day at the same location for our clinics. And this one-stop surveillance, this has to do with the primary care nature of treating these patients. And that includes referral for audiometry, surveillance for Mpnsts, monitoring for other malignancies. And there's also increased risk of stroke, heart disease, hypercholesterolemia in some of these patients. And then as for the research pipeline, Kostas, Dr. Hadjipanayis mentioned some of the research that I've done previously. Currently, I'm working with dermatology I'm writing up a grant proposal for topical immunotherapy treatment for cutaneous neurofibromas. I'm talking with psychiatry to enact a clinical trial of appropriate appropriate psychiatric interventions, both pharmacotherapy and talk therapy for NF1 patients. I'm considering writing up a drug delivery mechanism using nanoparticle technology for Nf2 and sporadic meningiomas. I'm talking with basic neurology and cancer biology to develop an organoid high throughput drug discovery methodology for Mpnsts. I'm already acquired off-label approval for immunotherapy in some of my Mpnst patients. And I'm looking into novel mechanisms to treat pain and schwannomatosis. So these are all just sort of seedling projects, but all of these are open to further discussion, and I'm very open to collaboration with colleagues in every department. So that is it. I will stop now for questions.
Rebecca, that was really an amazing talk. I mean, I think for the residents, a lot of these points that you made are going to be tested on their written boards. They love these types of genetic mutations in these disorders. One question I have for you in terms of neurofibromatosis 2 with unilateral vestibular schwannomas and the diagnostic criteria, because we do see those patients from time to time when they don't have bilateral vestibular schwannomas. I wonder if you could just comment just briefly on that.
So those patients could fall into that category of chimeric NF2 patients. Chimeric NF2 can be very difficult to diagnose. So this is one of those conditions where if you can get a second tumor and submit those for next generation sequencing, that would give us the diagnosis. But clinically, it can be really difficult to distinguish.
I wanted to echo what Kostas said and thank you for inviting Rebecca, Kostas. That was a really wonderful, interesting talk. So many of the points you made resonate with my own experience, and the last ones that you made may be the most resonant. The pain that some of these patients experience is probably worse than almost any other pain syndrome that I have seen. It is persistent, it is progressive. Almost everything we do to treat it makes it worse. And it's devastating. So I'm glad that you're keeping an open mind to look for collaborations, maybe with our neuromodulation group, perhaps, to explore new methods of stimulation, non-ablative therapies. But it is a terrible pain that they have.
Right. One of my just personal interests that I'm reading up on is primary neuropathy syndromes with NF1, NF2, and schwannomatosis. So it's thought that the issue is not just that you have a focal tumor that's compressing the nerve, but that the perineurium and the endoneurium and the microenvironment of the nerve itself is fundamentally different in these patients. And that there are hopefully potentially chemical signaling markers between the nerves and the nerve parenchyma and the tumor cells that can hopefully be identified, and novel therapies can be developed. But I think that our traditional pain therapies, as you mentioned, are currently insufficient. So I think there's just a lot of research to be done.
Who else has questions or comments from our residents? APPs, attendings, Kostas, Konstantinos?
Hi, Dr. Brown. I have a question. In non-NF patients, the traditional teaching is to, when you're dealing with a malignant peripheral nervous tumor, is to do a wide margin resection, like all sarcomas. Resect like 2 centimeters of normal tissue, make sure that you have resected all the contaminated tissue that looks like normal intraoperatively. But there's this newer concept that actually we have some limited experience here, where in lower grade sarcomas, you can go with an en bloc resection and actually have equally good results. In some of these cases, we might do adjuvant radiation therapy. I'm just wondering whether this could be something we can consider in NF patients as well, like en bloc resection followed by adjuvant therapy, the newer types of adjuvant therapy.
That's an excellent question, and that's an excellent point. It hasn't yet been studied in Nf1 associated malignant peripheral nerve sheath tumors. One of the limitations, though, is that the tumor is very rare, but I'm hoping, so this is kind of an aside, and then I'll come back to your comment. So adult Nf1 experts, adult Nf experts are pretty rare. And so I'm hoping that by providing an adult NF clinic, which would be the first in New York City, that I can really welcome and attract a lot of these patients into our clinic, and then have a larger patient base that we can explore with research that will ultimately come back and confer benefit to the patient population. Also, I'm neuro-oncology trained. A lot of NF clinics are run by dermatology. So I have the benefit of being able to administer chemotherapy myself instead of referring to yet another provider. But Konstantinos, I think that's a great question that we don't have an answer to. And, as the clinic grows, maybe it's something that we could explore in a small case series or even a proposed clinical trial, but we don't know the answers to that yet.
Has there been much in the way of publicity, communications, and outreach efforts on behalf of your clinic, which exists already? So it already is the first one, by the way. Not will be. It already is the first one in New York. Can we help with that?
So I have been my own worst enemy as far as that goes, because I joined Mount Sinai in January and hit the ground running. And I've just been seeing a million patients and focusing on clinical care. And I haven't been able to put the time in to really build our website. And once the website is built, then we can do all of the advertising and the reach out. That's the plan. And actually what I've done, some of you may have noted that I've closed my clinic, my general neuro-oncology clinic, to new patients for the next couple of weeks. And the reason being is that I'd like to get some grants in and really focus on the website. So more to come.
Okay, well, we discussed time management already, so I think that's going to be a big issue. Dr. Brown has become so busy that it's hard to even keep her own programs going.
Rebecca, I just wanted to make a comment. Fantastic talk. I think, there's so much interest in the genetic landscape for NF. And, we've been doing work on atypical meningiomas. And as you know, and as you discussed, the Nf2 gene is quite commonly seen in the more aggressive and recurrent meningiomas. What other aspects do you think are important in terms of the targeting, and what have you read in terms of the overlap between Nf2 and atypical meningiomas?
So atypical meningiomas are a huge growing interest of mine. I didn't see many of them when I was at Sloan Kettering, because at Kettering I was in the lab mostly, and I took care of the inpatients. And so the meningiomas were primarily cared for in the outpatient setting, at least along the lines of chemotherapy and neuro-oncologic intervention. But I've been working with Lyndon Kim here, as well as with Praveen. Through my perusal of the literature, what I find striking is that very few studies have actually shown tumor accumulation of drug. So my first question for meningiomas is the drug actually getting into the tumor? Is it getting into the parenchyma? And I suspect in many cases that it might not, whether that be a function of the tight cytological architecture of the tumors, or the basement membrane, or some feature of the blood-brain barrier around those tumors. I don't know. But yeah, my first question would be, is the drug actually getting in? Because it's sort of remarkable how resilient they are to literally every single chemotherapy and targeted therapy that we have. Now, as far as differences between Nf2 associated meningiomas and sporadic meningiomas, the genetic, the molecular diversity of these atypical meningiomas that are sporadic is much greater. And there's also thought to be particular genetic molecular profiles that might occur, for example, in the tumors that occur along the convexities or the perissagittal tumors versus the skull-based tumors, and posterior fossa versus anterior fossa. There's just, even this year, there's been new data that came out that's looking to subdivide meningiomas that might provide us also in the research side and on the clinical side with some more guidance as to selecting therapies so that we can determine subsets of meningiomas that might be responsive to certain therapies versus others. But Nf2 associated meningiomas actually have a low rate of progression into a grade 2 or grade 3 atypical meningioma for reasons that I'm not entirely sure about.
Has there been use of intraarterial chemo in the atypical meningiomas? We've been exploring embolization of various types of benign tumors with the endovascular team and getting outstanding results in terms of changing the enhancement pattern in meningiomas and even in schwannomas. I wonder if there would be a venue for alternative delivery if we're worried about the blood-brain barrier. That's something we could discuss with the endovascular team, perhaps.
Yeah, I want to say that I've seen at least one study in the literature of intraarterial, but can't recall, I have to say, which agent it was, and I think it would be worthwhile exploring further. We do have here, I think, one of the benefits that I recognized immediately upon coming to Sinai is the large number of advanced meningioma patients that we see here. I think it's really, that's a patient base that really needs to be tapped for research from the pharmacotherapy side.
Right.
Just speaking for myself in the neuro-oncology division.
Right. Other questions and comments for Dr. Brown?
Hi, Dr. Brown. Trevor, I'm one of the PGY4 residents. Great talk. Thank you so much for giving this talk to us. My question was just when you showed the genetic markers and mutations that are inherent with Nf1 and the difficulties in sequencing and modulating them, you mentioned that I think that you're looking at some of the CRISPR-Cas9 system modulation there. I was just wondering if you could talk to us a little bit about how you can combat and use that system to deal with those mutations.
Right. So this was the research I actually conducted at Sinai as a resident. It was my R25 funded research. And my idea was that there are so many different mutations in the Nf1 gene, and what they all do, in a sense, the way that they act is to inhibit the gap-related domain of the Nf1 protein. And so there have been characterized, not in humans, but in yeast, mutations that occur in the gap-related domain that enhance the baseline physiologic function of that domain. And so my idea was, to basically ignore the mutations and where they occur, but preserve the gap-related domain and generate a super enhanced function there so that we could overcome the haploinsufficiency and then hopefully overcome the possibility of a loss of heterogeneity in tumor formation. So the way that I did that, though, was I used CRISPR-Cas9, and CRISPR-Cas9 is a system. It's a protein-based system that was isolated from bacterium, and it requires a particular genetic code in order for it to bind and cleave the gene. And that code is GC-rich. And some of the issues I came up against were that the gap-related domain is so highly conserved that if I was going to genomically alter that domain, there would be implications for all of those pseudogenes I mentioned, as well as other gap proteins that are involved in different cell types and different signaling pathways. And so identifying a region that was unique to Nf1 was challenging. And then it ended up being very high in AT and low in GC content. And so it was even more difficult to identify a region that within that subregion that could be cleaved. And I ended up spending a great deal of time doing that. And I found some great, potential regions. But then when you induce a superphysiologic activity of the gap-related domain, you do that in a tumor cell model. And that tumor cell model is really good at dividing. And that's how you amplify that genetic modification. But when you provide a superphysiologic behavior to the gap-related portion of the gene that abrogates the cell's ability to divide. It basically takes away its tumor superpowers. And then I couldn't amplify that modification sufficiently in order to grow out my cells. And so I ended up abandoning that line of research in the laboratory, unfortunately, just because for reasons aside from it being a great idea, it was not scientifically, it wasn't possible in the lab.
That's really interesting. Thank you so much. That's awesome.
Sure.
Hey, Rebecca, one last question here. I think we're going to wrap it up here. But in terms of Avastin use, I know there's efficacy for these patients, and the question is, when do we initiate that? I know there's some difficulties getting it for them, but it's unclear to me when we start them on those types of treatments.
That's a great question, Costas. There's no clear answer to that. The answer is really, if we can have a timeline, an audiometry timeline for the decline in their hearing, if they've reached a threshold for hearing conversation, or if the patient subjectively is complaining of hearing loss and the audiometry supports that, then that would be a time to consider Avastin. And now, of course, what you have to do is rule out the possibility that surgery will be necessary for other reasons, because the maximum reduction of tumor size that we see is 20%. Subjective hearing improvement is much better for patients. And one of the reasons is when these patients have hearing loss, we with intact hearing, we imagine that it's just all sounds are quieter to them. And that's not actually what they're suffering from. It's that specifically conversational sounds are difficult to interpret. So there are some sounds that are loud, there are other sounds that are quiet, but if there's more than one person talking, then they can't understand the conversation. And so even though their audiometry response only improves in a certain percentage of patients and only by a certain percentage, the subjective improvement to the patient is much, much greater. So if the tumor is not of such a size, if it's not impacting the brain stem, that it would be safe to delay surgery and do a trial of Avastin, and the patient has audiometry proven hearing loss and is subjectively concerned, then that's a reason to trial an Avastin. One of the other questions is, what dose do you use? So for glioblastoma, I typically give 15 mg per kg every 3 weeks. For vestibular schwannoma, I start at 7.5 mg per kg, so a half dose, also every 3 weeks. And then after the patient has been stabilized after 6 months or so, when we start expecting to see audiometry findings, you can decrease the dose further to 5 mg per kg every 3 weeks, and then eventually space it out further, although that is clinician dependent. There's no actual hard and fast guidelines as far as the dosing and the scheduling.
Awesome. Well, that's great. That was just a really nice talk, and we really appreciate you spending the time with us this morning. I think we're going to wrap it up here. Thank you again.
Just a note for the residents and for any of the attendings, if anybody is interested in coming to the neurofibromatosis clinic or has ideas for collaboration on research, both myself and Praveen Raju are happy to discuss. And also, I am going to eventually generate just a lot of tissues from these patients: cutaneous neurofibromas, vestibular schwannomas, malignant peripheral nerve sheath tumors. Anyone involved in basic research, if you're interested in a tissue pipeline, we can set that up hopefully along the next year or so.
Thank you so much.
Thank you.